we do not directly study and some of the area you mentioned, and we just look at the general pain matrix.
So is there any correlation though with the way your palate would be arched or narrowed and just the whole shape of the cranial base, like affecting the brain? Does that change how it would even record on the measurement and on the healing?
Oh yeah, I mean, I think, because this part is so vulnerable to blast, and that's the most of the patient we see so far, and also happen to be, when you see my talk, the vast majority of this slow wave, the potential injury, and not from the back part of the head, occipital, pretty normal, parietal, some in the slow wave, but a lot of from the frontal area, the anterior frontal and the anterior temporal region. If you look at the skull curvature, like the mouse, this curvature is not regular. To make the brain like a jello, and when doing the TBI, the move forward backward, there's additional maybe damage to the other structure of the bone. But that's explained. We see a lot of those injury in the frontal area. So frontal area is more vulnerable, same as the anterior temporal, more vulnerable to TBI. They say that the occipital area or the parietal region, when the skull tends to be very smooth and spherical, and the fourth actually don't cause that much damage in those regions, but the frontal area tend to be more vulnerable.
Thank you.
Hello? Working? I actually have 3 questions, but Dr. Val didn't make it, so if I can ask 2. So for Dr. Beth, my 5-year-old has 70% obstruction, tonsils, and they're saying he'll grow out of it or surgerize. He's a mouth breather. He snores during waking hours, very audible breathing, but he doesn't have any habits. So do you think that the enlarged tonsils are a result of the mouth breathing acting as the primary filter for everything that's going in at night? And will the system Healthy Start help him with all that? And then should I just ask my second question? You guys can. And my other question is for Dr. Sammy about alumina in ceramic implants. Is there a biocompatibility issue with that material or any toxicity we need to worry about with aluminum and aluminum oxides, for example, in Ceraroot or in some of the other brands?
Okay, otherwise I might forget. No, that's such a great question for anyone who wasn't able to attend my talk. We talked about pediatric sleep disordered breathing. If you don't know anything about it, come find me this evening or tomorrow. I'd love to loop you in. But specific to your question, tonsils are an interesting subject. If it's grade 1, grade 2, we always put the habit corrector in, and we see a lot of that inflammation decrease. Saying he doesn't have any habits, like not thumb sucking, technically a habit of mouth breathing is a habit, and he has inflammation in the nasal passageway that you have to overcome as well. When you're getting to grade 3, almost grade 4 tonsils, that's where we don't see complete reduction of that inflammation. How old did you say he was? 5. So 5, they're so pliable, malleable. Having your kid go under general anesthesia, have surgery, the recovery from that is tough. So getting started with the habit corrector, you will definitely see a decrease in that inflammation. A lot of the kids will put on nasal lavage to kind of decrease that inflammation of the nose, promote the nasal breathing, get the shrinkage of the tonsils, which may, even if he does end up having to have his tonsils taken out, may make the surgery much more easier to recover from, because he will already be ready to go and it won't be as severe, and he'll be used to breathing through his nose during that recovery period. But this is just a quick way. Let's put the appliance in there. Worst thing that happens, what would probably happen, is the appliance falls out at night because he's just so used to mouth breathing. We see that even in kids who don't have really inflamed tonsils, but after a week or 2, kids are so adaptable. You might be surprised he'll start breathing through his nose, sleeping with his mouth closed, those tonsils are going to decrease in size quite substantially, and then it can become a parent call if you can get it from a 3 to a 2 and he's not having frequent throat infections or any other issues, you may elect not to have that surgery. There's a lot of different research and it's pretty polarized as to which direction to go. If it's a grade 2 or 1, we typically say no if they're not having frequent throat infections and the kid is 5, 6, 7 or older. But if it's a 3, 4 and it doesn't reduce in size, then we typically encourage it. But we partner with our ENT and he's really on board with what we're doing because he can see the benefit to his patients. So it's a very collaborative effort. But specific for your kid, I would encourage you to try the intraoral appliance first, see what kind of reduction in inflammation you can get and go from there. Does that answer your question? Awesome.
Okay. Your question was about aluminum? Okay. The components of the ceramic implants is zirconium dioxide in general, yttrium dioxide, and aluminum dioxide. Okay, but those oxides of metals have transitioned. They have lost their metallic structure and become crystals. So we're not talking about elemental aluminum. That's not what we're talking about. We're talking about alumina, which is a crystal phase. So the concern, I've heard this before, oh, well, there's aluminum in that implant anyway. Well, there's no ceramic implant that does not have alumina in it, not aluminium. So remember I showed the powders on the table mixed together? That's the powders, those are ceramic powders. There's a ceramic components of those materials which are transition metals. So the concern about having aluminium in an implant, it's not valid. Exactly, that's the word. You know, so a lot of people don't understand, and they go around and they speak, and I've sat in rooms and they say, well, CeraRoot or whatever other implant has aluminium. That's not true. It's the alumina that's there. It has aluminum dioxide, not aluminium as elemental aluminium, you know, that's out there. So it's not, or aluminium in any form. It's aluminum dioxide, which is alumina. Mm-hmm. That's correct. Who's that for me?
Sorry, the question again?
Does the family of cholesterol medications have any effect, their usage on the healing of traumatic brain injuries?
I think there is, but you know, right now, you know, there's not a specific medicine designed to treat TBI. And when we're dealing with TBI treatment, we're dealing with the symptoms, you know, and this headache, treating headache. There's memory issue, you do therapy, you know. And so right now, you know, there's not a specific drug or medicine target TBI per se. And the only thing actually I know actually work well in surprisingly fish oil, omega-3 fatty acid. There's quite a few animal studies shows, and even after the TBI, after the the animal experience was either blast-based or the impact-based TBI, if you give the animal a relative high dosage of omega-3 fish oil, and then that speed up the healing mechanism a lot, and so. We also actually do a small study in our VA and also with the DoD, and give our veterans or active duty military personnel and relative, not terribly high, but higher than the typical dosage of omega-3, and so that actually shows us beneficial. Agree with the animal research, and so back to your question, I'm not aware of directly there's any specific, medicine actually work to treat TBI per se, but, I strongly recommend people with concussion and TBI and take, omega-3 fatty acid. And the other idea, take home message is, and help the brain and heal fast is sleep, Sleep actually is, I cannot emphasize it even more. It's one of the best natural mechanism happening every night. And so we see, and our patient with sleep disturbance, they really have tons of symptoms, and same thing, other disorders like, early Alzheimer's disease development. And a lot of, and the patient, if you look at them, they have history of sleep deprivation, So without a good sleep, as shown by the paper I discussed this morning from Shea and colleagues, and there is accumulation of beta amyloid, and as a result of TBI and other disorders. And without good sleep, those toxic chemicals will accumulate across years. And that's one of the major factor, I think, generate, in the long term, and the cognitive functions and other symptoms associated with TBI, and also potentially we know TBI, typically repetitive TBI, and the patient have high risk develop dementia, and the link is the beta amyloid, I believe. So, and if people with TBI, the things I recommend to them, try the best you can, sleep well, and take some omega-3 fatty acid to help the brain with the necessary compound to recover fast from the injury. But I'm not aware of any specific family of drugs, and that's specifically designed for TBI. Most of them are treating symptoms.
Go sleep.
Yeah, that's the take-home message.
Take home.
Yeah.
At every age.
I just wanted to see, you can take your question, but I want to add something just not about your area. I can't do anything about brains. But there's something that I forgot to mention, and probably most of you know, because somebody approached me and said, well, they're trying to get their surgeon to start doing ceramic implants in their office. Well, one thing I did not say in this lecture is ceramic implants behave very, very differently than titanium implants. The way they integrate is different. So one thing that you really want to do is assess your patient systemically. What I generally, not all the time, but not systematically, but I tend to always try to, because the question was about cholesterol, I tend to want to see where their cholesterol is at, their vitamin D3, their red blood cell magnesium, as well as A1C. And also, if they have a history of taking antidepressants, SARIs, selective serotonin reuptake inhibitors, these are medications and nutrient deficiencies that can lead to implant failure. And ceramic implants are very sensitive to the types of medication patients take, the deficiencies they have, the fat in their blood, and things like that. So I just wanted to throw it out there. Just don't convince your surgeon to do it. Just your surgeon has to buy into a concept. This is not, titanium implants do amazingly well. The kind of inflammation they trigger when you place it is slightly different than the one from the ceramic. Ceramic sits there and waits for bone to happen, whereas titanium does it differently. There's surfaces that are bioactive. The surface of zirconia is not bioactive. It's there. It just waits to be hugged, so to speak. So I just wanted to add that.
Sort of a follow-up question. So his question about certain, say, medications, or your answer of taking fish oil sleep to help overcome a TBI, in terms of avoidance. So you have trauma, I guess there's micro trauma that can lead to that, whether there's like vascular events, whatever we would classify as a brain injury. With those, it would, I guess, stand to reason that those same things would help the brain avoid a certain types of injury. or not? Or do you have anything to say about that?
And good question. So, and right now we know, and the brain actually, the people used to have a concussion, a bump the wall or fall, whatever. And it just happened just once, and without any treatment, and for mild TBI, we'll talk about. For the more severe and TBS, different story, there's a bleeding in the brain. You can see that with CT MR, there's different story we talk about. And most negative cases in the structural imaging, CT MRI didn't show anything. Didn't show any detectable blood in the brain. And we call it mild TBI, a concussion. Those patients just experience one concussion, and the brain can recover and repair the damage. And so by 3 months, most people symptom-free, and so the brain fully recovered from that. But still a subset of about 25 to 30% by 3 months, 6 months, they still have ongoing symptoms. And those are the ones we study a lot. And we try to understand what happened in the brain and why the vast majority of people recover very well. Those subset of patients actually didn't do very well. Those subset of patients have ongoing symptoms and they cannot hold the job, and they even go to school, they fail, and this. So, and in the long run, they also have high likelihood to develop, for example, epilepsy or dementia. So we try to understand the association between the number of concussions and the final outcome. Our experience is 3. If the people have 3 concussions and the outcome is not looking good, and most people have 1 concussion, sometimes even 2, they're okay, In most cases, can recover by that, but they have a repetitive, and the concussion, like American football players and like boxer, and some of the we see even play soccer. They use the head a lot, Sometimes don't have to lose consciousness to be classified as a concussion. It's just a repetitive contact, an impact with the soccer ball, and can have long-term symptoms and deficit. So, and they don't need to have a bleeding in the brain, but the repetitive type injury, is high, at high risk develop CTE, and they also, and I mentioned, epilepsy. We see a lot of patients with epilepsy. They have previous head injury, and not remittingly. Can be 6 months or 1 year, sometimes 3 years before you have a concussion over there. The increased likelihood of those more devastating neurological disorders.
Okay, I have a question for young Dr. Cooper. Could we get her the microphone for a second? Could you tell me what is the best kind of ice cream?
What's your favorite ice cream? Vanilla.
Vanilla. I like it. And one more question. Cake. Chocolate or white?
White.
All right. Thank you very much.
Thank you to our speakers for a wonderful job, and thank you for all our attendees. Have a great evening.
Thank you.